Hello, web shadowers. Thank you all for attending our session today.
This afternoon, we have the pleasure of hosting Dr. Schirtz again, who will be teaching us all about pediatric gastroenterology.
And as always, please remember that the Google form will be posted in the chat box and in the description of this video at the end.
So with that being said, Dr. Schirtz, you may start whenever you're ready.
Awesome. Thanks y'all so much for having me back. So my name is Dr. Joanna Schirtz. I'm a pediatric gastroenterologist. This is my third time now presenting for web shadowers. The first two lectures we covered reflux and constipation, and the second lecture we did foreign bodies. And today we're going to talk about IBS, IBD, and celiac disease. So let's get started here. I have no financial disclosures. Nothing that I talk about today during the presentation is a representation of my employer. So a little brief background about me. I think I went a little more in depth during the first two presentations, but since this is more of like a continued virtual shadowing, I won't get too into it. But I'm from Europe. I was born and raised there. I've come back and forth across the pond multiple times. I did my undergraduate studies at Northwestern. I majored in biology and anthropology. And then I actually went back to Poland, where my family's from and where I grew up for medical school. I came back to the United States for residency. And so I did my residency in pediatrics at the University of Tennessee. In Chattanooga, Tennessee. And then my fellowship in gastroenterology at Emory in Atlanta. And I've stayed in Georgia now, and I'm practicing in Georgia. And so if we were really truly live in-person shadowing, you would obviously notice I'm getting to be a little bit more slow. I am pregnant. I'm due in 2 months. So that would be kind of a fun thing, I guess. But what I want to let you know is every time I have students and medical students, residents, fellows, I want you to know how passionate I am about these three topics. And this is what I love seeing in my pediatric clinic. I'm really passionate about inflammatory bowel disease. That is my actual career focus. And so I do a lot of my research in inflammatory bowel disease, my quality improvement. I'm the director of what's called Improve Care Now at our hospital, which helps patients and families get standardized care for inflammatory bowel disease. And so that's kind of where my focus is. So I'm super, super excited about the presentation today. Okay, so we'll just jump in. So what you'll notice is we'll use a case presentation that is very similar for all three topics today. So IBS, IBD, and celiac. And you'll notice that some of the history can be very similar for all three, and you really have to tease out the differences or the details to be able to kind of help you figure out what's going on. So we'll get started with Julie. So she's a 16-year-old female. She is brought in by her mother for the chief complaint of abdominal pain and diarrhea. She's been otherwise well, no past medical history, but what she did notice is diarrhea that started about 3 months ago. And she wasn't sure what it was, but she let it ride for a little bit and it didn't go away. She has some abdominal pain that's off and on. It really doesn't improve with bowel movements. So that's kind of important to know too. And her bowel movements, she has about 4 to 5 a day, Bristol 5 to 6, which you'll see in a second what that means. And she's had a 5-pound weight loss in the last 3 months. Nothing else is really going on. No vomiting, no blood in the stool, no fevers. she's well otherwise. And so if I had a patient like this in clinic, there are other details I would ask about, like family history and maybe travel and exposures, definitely about her diet. But these are the main things you want to know. And so we did some labs, regular routine labs. So metabolic panel, a blood count, so her stool studies, which were infectious studies and or inflammatory studies, those were normal. And we didn't really feel like she needed imaging of any sort at this point. And so this is a Bristol stool chart. This is one that I talked about a lot in the first presentation. Us gastroenterologists, we love this stool chart. I actually have one in clinic in every single patient room. And it's funny, you know, people start to laugh when they see it. And but I like it because it really is hard to describe what normal is. So when someone tells you, hey, I have normal stools, so their normal might be completely different from my normal or your normal. And so what does that mean? So is their normal like type 2, which is kind of considered constipation, or is their normal like type 6, which is kind of loose? Or is it truly like type 4, which is what I like to refer to as soft serve ice cream? It's kind of, kids kind of get grossed out by it, but honestly, like that's the way their stool looks. It's formed, it's soft, easy to pass, no lumpy bumpies, and that's it. So, all right. We go through her Bristol stool chart. We do all of this on that we mentioned. And so now we're really thinking about what could this be? And I'll show you the diagnoses or diagnostic criteria for IBS, but I wanted to start with IBS because April is IBS Awareness Month. So if you follow any GI docs or pediatricians or internal medicine doctors or family practitioners, we will talk a lot about IBS this month. And so what is IBS? It stands for Irritable Bowel Syndrome. And when you use acronyms, like with 3 letters, it can sometimes sound like other things. And so it is not IBD, which is inflammatory bowel disease, which we'll talk about next. But IBS is Irritable Bowel Syndrome. And it's a problem with the digestive system that can affect normal functioning of the gut. And what it really affects primarily is the large intestine. So I'm not sure if y'all can see my cursor here. But in the picture, there's esophagus where the food travels down into the stomach. It gets digested in the stomach or broken down into smaller pieces. And then it gets passed into the duodenum, which is the first part of the small intestine. And then you have feet and feet and feet of small intestine. Your small intestine is super long. And then the last part of the small intestine that connects to the large intestine is called the ileum. And the ileum will also be very important within the next topic, IBD. But the ileum feeds into the large intestine called the colon. And this is primarily where IBS is affected. And so there's no true change in the bowel tissue inside of the colon. And what's really important is there's really not an increased risk for cancer, for colorectal cancer. And so that's really important for families and patients to know because everybody gets nervous about cancer. And if you debunk that right away, it makes them kind of breathe and you are able to really connect with them because you know that one of their biggest fears, which is cancer, colorectal cancer in this case, is not a thing. And so especially is in IBS, irritable bowel syndrome. And so what else do we know about it? Well, it is a chronic condition. Very severe signs and symptoms are rare. So meaning hospitalizations, ER visits for, dehydration, death, those are extremely, extremely rare for IBS. And what is cool is most people can control symptoms by managing their diet, lifestyle, and stress, but it takes a long time to figure out what part of their diet, their lifestyle needs to be changed for them to feel better. And that's the biggest thing for IBS. So is it common? Can I be affected? It's pretty common. I think a lot of people don't even realize that they could have it and they deal with it. These are just some statistics. So IBS affects between 25 and 45 million people in the United States. And that gap is pretty large. And you can see that. And that's because there are a lot of people that don't know that they have IBS. About 2 in 3 IBS sufferers are female, meaning 1 in 3 are male. So it is more predominant in females. IBS affects people of all ages. So we, as pediatric gastroenterologists, see this in children for sure. Worldwide, it's estimated that 10 to 15% of the population has IBS, which is a lot of people. And most people are under 50, but older patients can suffer and they can get diagnosed later on as well. So is it serious? It is serious because it can affect the quality of life. And if it affects the quality of life, that means things like normal daily functioning is affected. And these 2 statements are so important. So one study showed that a majority of patients with IBS would give up 10 to 15 years of their life expectancy for an instant cure for their condition. That is crazy, right? That should speak, wonders. I mean, this is serious. And then another study found that patients with IBS would accept a median risk of sudden death of 1% if a hypothetical medication would just cure their IBS symptoms. And so I think that is the biggest thing to know, is that it is serious because quality of life is very much so affected. So cause and cure. So we don't have a definitive cause. And there's really no true cure in IBS. It's a long-term problem that we try to manage with diet and lifestyle and some medications. But our biggest goal is to get patients to a manageable level of functioning and increase their quality of life. And so the cause of IBS is multifactorial, meaning that it can come from all different sorts of things. These are just some of the examples. So a hypersensitive gut wall, and then bowel motility and pain sensitivity changes. So what that means is, I like to explain this to my patients, is your sensitivity is different than mine. And what you're sensitive to, I might not be sensitive to, or vice versa. It's something like if you have, if it's raining outside and you hear the drops of rain, and I can completely ignore those drops of rain. And when it's raining, for me, it's like the best time to go to take a nap. But you're constantly hearing those drops of rain. And so you might be more sensitive to that weather or to those drops of rain than I am. And you can't shut those down. And so that sometimes can happen with pain sensitivity changes in IBS patients, where they just can't shut down that pain, and they can't shut that down, even though we might be exposed to the similar kinds of triggers. Sometimes IBS can occur from post-infectious processes. So I'll show you later on what those can be. I hear a lot of patients say, I was fine until 2 weeks before Christmas. And 2 weeks before Christmas, I developed this terrible stomach bug. My whole family did. Everybody recovered, but I'm still having symptoms. Why is that? And so that can be the onset or start of IBS. Stress and the gut-brain axis. There are a lot of studies that are coming that show that the brain and the gut are absolutely connected. So think about it this way. For example, if you have a huge test or a huge exam coming up, And that morning, your stomach just doesn't feel right. And so you are going to the bathroom and you have diarrhea, for example, or before a presentation or an interview. What you're feeling and your emotions and your stress is being kind of exposed through your gut. And so your gut is showing signs of, diarrhea, for example, or loose stools or belly pain. So that is really related. IBS is really a combination and can be a combination of the gut and the brain axis changes. Genetics have definitely proven to be part of IBS. And I'll show you some statistics, but it does run in families. Prior antibiotic use, and that kind of ties in with the gut microbiome. So sometimes IBS can get started after taking a certain antibiotic, and you disrupt the microbiome in the gut, and you have these symptoms that start back up. And then food allergies and intolerances. So common IBS symptoms. These are just a few. Constipation. So remember on that Bristol stool chart, there were the ones that were Bristol 1 and 2, hard balls, or balls that are kind of put together but are difficult to pass and hard. Diarrhea, which is more towards the end of the Bristol stool chart, which is loose stools, mixture of either. So I'll show you a little bit about the definitions of IBS and what that means. And you can have a mixture of constipation or diarrhea. Mucus and bowel movement. So it's a little bit, it looks different than what you're normally expected to see. And that can kind of be alongside diarrhea. Feeling of incomplete bowel movement. So you go to the bathroom and in 30 minutes, you feel like you have to go back. Looser and or more frequent stools. So you can have maybe you're not constipated or you don't have diarrhea, but you're stooling all the time. So that increased frequency is also part of it. Abdominal pain and bloating. And so that is something you can see with either constipation or diarrhea subtypes. Other things, for example, fatigue, psychosocial changes like anxiety and stress. And so all of those are common IBS symptoms. And then, so we have these symptoms. Is this enough to make a diagnosis? We use this room for diagnostic criteria for irritable bowel, which really has one main thing and then two of the following criteria. So the one main thing is chronicity. So you need to have symptoms for at least 3 months. And then recurrent abdominal pain on average of at least 1 day per week in the last 3 months. And then 2 or more. So you can have changes in your bowel movements, so related to defecation, associated with a change in the frequency of stooling, so stooling more, associated with a change in the form or the appearance of stool. So you normally had like a Bristol 4, and now you're having like Bristol 6, for example. And these criteria should be fulfilled for the last 3 months with symptom onset at least 6 months before diagnosis. And so that, but I will tell you, most patients I see are dealing with this for a lot longer. And usually the chronicity is not something that needs to be established by the time I see the patient. All right. So is there anything else we really need to do when it comes to the diagnosis? So we might do some lab work, which includes like metabolites, so CMP, a complete blood count, and then ESR and CRP are inflammatory markers. We might include some things to rule out celiac disease, for example, which we'll talk about those, and then stool studies. And some of the stool studies, a stool study that I really, really like is called fecal calprotectin. And you'll notice that, especially with inflammatory bowel disease, which we'll talk about next, that is really important. But if this is normal, then we can really say that there's no true mucosal changes or damage inside your gut. And that kind of helps with the diagnosis as well. And there's really no need to check for infectious stool studies. If this has been going on for 3 to 6 months, usually something like a stomach bug from a virus, for example, is going to clear up by then. And there's really no need for a scope at this point, meaning looking inside the gut. And so this is a kind of cool picture of the different IBS subtypes. And so the way you would read this is if the majority, I apologize, I still don't know if y'all can see my cursor here, but I'm looking at the y-axis here. And so Bristol types 1 and 2, those are the hard stools, the hard balls. If you primarily have 25 to 100% of your stools looking like that, then you'd be considered IBS-C or IBS constipation. If down here, your primarily stools are more of the Bristol 5 and 6, so loose, you would be considered IBS-D or diarrhea. You can have a mixture of both. And what you can see with this graph is that all 3 subtypes are pretty equal with one another. So it's not like primarily IBS-C is the most common. They're all very equal. So equal number of patients have IBS-C, D, or mixed. And this IBS-U is when we don't really know what's happening. It can be early on before the diagnosis, or you have normal stools and then occasionally you have a stool that's diarrhea-like or constipation-like. So it's just not clear. And maybe with time, it'll present as one or the other. Okay, treatment. So there are a lot of options. I will put them all on the screen and then we'll kind of go through them. But what you will notice is that a lot of the treatment is centered around diet and lifestyle changes. So for example, for dietary changes, I love to ask my patients to bring in at least 1 week, if not a 2-week food journal or diary. And I want them to say what they ate for breakfast, lunch, dinner, snacks, when they had symptoms, when they had a bowel movement, how many they had per day. And that really helps see if there are any known triggers. And this doesn't only help me, but it also helps our dietitians. And in my clinic, we have at least 3 dietitians there every single day. And so every visit, a patient can see the dietitian. And so they can really help to see if there are any red flags or triggers. There is a diet called the low FODMAP diet, and we can trial that for IBS if we notice that there could be some triggers in foods. And what this means is, it's a very long word, but it means low or eliminating dietary fermentable oligosaccharides, disaccharides, monosaccharides, and so it's really, FODMAP is just really nicely kind of an acronym for it. And FODMAPs in general, what they do is they increase GI water secretion and increase fermentation in the colon. And so this can produce something called a short chain fatty acid and gas, and that can lead to bloating and distension. And that can be triggered by certain types of meals and foods that patients eat. And that can produce the symptoms of so bloating can be, for example, pain. So if I decide to start the low FODMAP diet with for a patient, I always incorporate our dietitian. This can be a 6-week program where we take out a lot of types of foods and we slowly introduce them to see if we can find that potential trigger that patients may have. Other things that we can do within the diet is increase fiber. So for adults, the goal is 25 to 35 grams per day, and fiber is really good for you. And increase fiber organically, meaning through the foods, the fruit and the vegetables you're eating, not the fiber that you can buy over the counter. The thing that I love for a lot of my patients is peppermint. It has been studied and it has been proven to help with abdominal pain and other symptoms. This patients can buy over the counter. They can buy them on Amazon, and I kind of teach them how to ramp up how much they're going to get. And then if you have a primarily constipation like IBS, then there's some geared things we can do for constipation, which may or may not include stool softeners. There is a new medication, lubiprostone, that we are using, and it's been very successful and helpful. And then things with diarrhea too. If it's chronic, maybe we want to control some of the bacteria that are in the gut that can contribute to it. So we use an antibiotic called like rifaximin to help with that. And then the last thing is, remember how we talked about that a lot of IBS can have that brain gut axis interaction. So there are a lot of studies that have shown that using help from like a psychologist to work with CBT, which is cognitive behavioral therapy, as well as gut-directed hypnotherapy, those can absolutely help with the success of IBS and treatment. One of my personal goals is to become certified in gut hypnotherapy, to give that as an option for my patients, but also to understand it, to be able to see which patients would be really beneficial to get that therapy as well. So I think those are really, really cool. Okay. So I'm just checking my time here because we have 3 topics. So we have 3 topics to cover today. I want to finish with IBS. I want to do IBD. If we don't get to celiac disease, then I will have to come back and talk to y'all about that, but I'll try to go a little bit faster. These are questions that y'all sent through Instagram. And so I wanted just to hit them for IBS specific questions. I wanted to talk about them quickly and make sure those are answered. If there are ones that I haven't answered, please message me directly too. Is IBS on a spectrum, or is it more like an all or nothing thing? So it can absolutely be on a spectrum. But once you have the diagnosis, you have the diagnosis. So, and that's primarily why, and the spectrum part of it is like mild, moderate, severe. So you can have mild IBS that you can control. You can go to school, you can play sports, but then some people have IBS that's severe that prevents them from going to school. They miss tons of school. They miss work. They can't play sports anymore. And so that part of it is what I like to look at it as a spectrum. Treatment of IBS, we talked about triggers of IBS reactions. So this, and then what are the ways to prevent IBS flares? So once you figure out what your triggers are, it's a lot easier to manage, right? And so sometimes if you know that your trigger is a FODMAP, a certain FODMAP food, then you avoid that. Sometimes alcohol, chocolate, caffeine, those can be triggers for patients. Large meals, stress, anxiety. So those are all things that you can try to control to be able to minimize the triggers. Any diets that help? Yeah. So we talked about the low FODMAP diet. How do you prevent IBS? So that's a really good question. And as you could tell, like you don't know because we don't have a certain thing that causes IBS. You can eat healthy, live a healthy lifestyle. But it's really difficult to prevent it completely because we don't know what causes it. And there are definitely things that we can treat without going straight to medications. We talked about the different types. How long can one go on living with IBS? So best case scenario is you figure out your triggers and you learn how to minimize your symptoms. But it is very common that folks with IBS live with symptoms of IBS for a very long time. And how often do I prescribe a low FODMAP diet? If I think that your triggers can be food related, I really try to push that. And I've seen so much good success with my patients because we have such wonderful dietitians that help out. Okay, so moving on. We're back to Julie. Julie is our 16-year-old here with abdominal pain and diarrhea. So everything is pretty much the same except she has this thing called nocturnal stooling, which is which means that she has to wake up from sleep in the middle of the night to go to use the bathroom. Most people with IBS, that does not happen to. However, now moving on to our next topic, this is very common. And then we do labs, and our labs are not normal anymore. So now we see a low protein level, which is albumin. We see elevated inflammatory markers, ESR and CRP, and we see anemia, so low hemoglobin. And so this is a telltale sign that something is going on that is different from IBS. We do some stool studies too. And now we don't have a normal fecal calprotectin, but it's elevated. So the fecal calprotectin is a stool study that measures direct inflammation in your gut. And it is elevated. And infectious stool studies for this patient, for example, were also done. They were negative. So we're thinking more of an inflammatory bowel disease at this point. There are infections that can mimic IBD. So it's important to sometimes exclude these infections, especially in patients that have bloody diarrhea. So our patient didn't have bloody diarrhea, and I'll show you which subtypes of inflammatory bowel disease have bloody diarrhea and some that don't, or that don't have to have it. But in any case, you do stool studies, you want to make sure that you don't have C. diff, which is common with patients with inflammatory bowel disease. Salmonella, Shigella, E. coli. And then there are some bugs that can actually mimic Crohn's disease, and Crohn's disease occurs in the ileum, so that last part of the small intestine right before you get into the colon. Things like tuberculosis and Yersinia. And so we don't see it very often, but it can definitely be there. And so here's a great picture of IBS versus IBD, because they can be confusing. And actually what's interesting is that there are patients with IBD that can have symptoms of IBS, and that gets really hard for us as gastroenterologists to tease out if this is more of their IBD, so the disease part of it, or IBS, or the syndrome part of it that's happening. And so you can see that both of them are chronic, so meaning you can have it for a long time. Similar symptoms like Julie had initially. They can both have problems with their quality of life. And both are really manageable, but not fully curable. Asterisks there, because there's a form of IBD that you can cure with surgery, but we'll get into that. But IBD, so chronic inflammatory disease. So that is why it's more called the disease and not a syndrome. It can be life-threatening, caused by inflammation in the actual gut. There's also a genetic component to it, just like IBS. It is less common than IBS, and it can be treated with surgery. So those are the biggest differences between the two. So inflammatory bowel disease, there are two main types: Crohn's disease and ulcerative colitis. There is an IBD-U, so like an undeterminate, and that's when we just don't know exactly which one of the two it could be. And it's chronic inflammation in the GI tract. So first, Crohn's disease, it can affect any part of the GI tract, from the mouth to the anus. In the picture here, you can see that it is all of any part of the GI tract can be red. So here there's redness. You can have it in the stomach, you can have it in the colon, you can have it in the small intestine. It's patchy, meaning it can be here, it can be there. It doesn't have to have a continuous inflammation in the gut. And with Crohn's disease, it can actually penetrate through the lining of the gut and cause things like fistulas, which are connections between organs. It can cause abscesses. It can cause a lot more a lot more or different complications than ulcerative colitis. And then ulcerative colitis occurs primarily in the large intestines of the colon. So the redness you can see here, this is the large intestine, and that's where it's affected. And it usually starts from the bottom, your anus and your rectum, and it goes back, it goes up. It doesn't always have to do that, but that's primarily what we see most common. The inflammation is more continuous, not like Crohn's, which is patchy. And it stays within the mucosa, so it doesn't produce those deep fistulas or connections between the gut. And IBD prevalence. So this graph shows, so the red is the biggest hotspots for IBD, and you can see Canada, United States, parts of Europe, Australia, those are the most prevalent areas. What's important to know is that 25% of IBD occurs in children. So it's absolutely there. We see it as pediatric gastroenterologists. And it's actually the fastest growing group of patients. And so whether that's because we're noticing it more frequently, we're better at diagnosing it. The general pediatrician can also help with that initial diagnoses, and we just have a lot more awareness of it. Not sure. So the cause of IBD can also be similar to IBS, where it's multifactorial. So there could be a few different things that can contribute to it. There's a lot of causes that can modify one another. So there are hundreds of genes that are looked at. There are some that are more predominant in Crohn's disease or ulcerative colitis, but there's not really that one gene or group of genes that will say you absolutely have inflammatory bowel disease. There can be changes in the environment, things that you're exposed to, a certain diet or certain trigger that can, if someone is susceptible to it, can start the process of that gut inflammation. And there can be an imbalance in your immune system too. And so we don't know, we don't know what combination of these three. It could be other things too that tells you, like, you will start to have symptoms at 7 years old or at 18 years old or at 32, that we don't know that exactly. But what we do know is that there's a patient that's susceptible, and then there's a trigger that usually starts the process up. So there's a genetic predominance too, that you can see here, the relative risk of a sibling, for example, of an affected individual compared with the general population. So it's more so in Crohn's disease and ulcerative colitis. Usually if you have one or the other, you have affected relatives, and up to 20% of the time, the younger you are. So in pediatrics, the more likely you'll have a family history of some sort. And then the genetic influence is lower in ulcerative colitis than Crohn's disease. So those are some things we do know. So presentation, signs, and symptoms between the two. So where there are more pluses, those are more time telling of one or the other. So rectal bleeding, remember in ulcerative colitis, where that inflammation primarily starts in the bottom, so rectum and anus, and it kind of goes up. So you can see more of that blood and stool because it's more fresh, right? It's more close to the end of when you have a bowel movement. Abdominal pain can occur in both. Diarrhea can occur in both. Weight loss is primarily or more so associated with Crohn's disease, and so is growth failure. And then perianal disease, even though in ulcerative colitis, that disease starts in the rectum and goes up. Perianal means on the outside. And that primarily shows up with Crohn's disease. And then you can have all of things that are not GI manifestations. So mouth ulcers, erythema nodosum is a rash that you can have, fevers, low red blood cell counts, and arthritis, so pain in your joints. Okay, so we think someone has inflammatory bowel disease, and we the next steps, we're going to do a scope. So usually the scope is an upper scope and a lower scope. So we go through the mouth and go into the stomach. That's the first part. And then we do a scope of the colon. And here you can see pictures. So on the left here, this is the ileum, that last part of the small intestine. Looks normal on the left, and then Crohn's disease in the ileum. You can see this like pussy ulcer-like change. So that's not normal. And then in the colon, so this picture right here, if you can see my cursor, this is normal colon. So it's smooth and shiny. You have normal blood vessels here. Those are normal. Here you can see those. The folds look beautiful. And then ulcerative colitis is in the middle here. You kind of lose that nice pattern of vascularity, meaning these vessels. You see a lot of redness. You see a lot of kind of angry tissue. And then here in Crohn's disease, you can see those deep ulcers or fissures here, cobblestoning. And then when you take a biopsy of this, you can see what's called a granuloma, which is a collection of cells that's very diagnostic for Crohn's disease, but not all patients have that on their biopsy findings. And here's another picture. On the right, you can see this deep ulcer, which obviously does not look like this nice smooth colon that we would like to see. So treatment goals for IBD, we want to get the best bang for our buck. So we want to pick a treatment that's going to enter the body with the fewest side effects, the best therapy for healing the mucosa, and then the best potential for growth and development and quality of life. So those are our biggest and best treatment goals. And this is kind of the pyramid that we can see. I'm not going to get into all the details of these medications, but what was thought of in the past is you start from the bottom. So you start from medicines that are by mouth in both Crohn's disease and ulcerative colitis. And then if that doesn't work, you start steroids. If that doesn't work, you do these types of immunomodulator medications. If that doesn't work, you do a biologic, and then you end up with surgery. What we are seeing now is if we start higher in the pyramid sooner, it can actually prevent getting to this top part or surgery. But it comes with different medications. These are all different types of medications that we use for inflammatory bowel disease. Some are ones that we've used for a long time. Some are brand new or just now starting to be used more frequently. The two most common ones for Crohn's disease, for example, is the top two, Remicade and Humira. For ulcerative colitis, there is a possibility to start a by mouth medication that oftentimes can work. And here on the bottom, you can see steroids. And we don't like to use steroids. They're like a Band-Aid. They make patients feel better, but they can have a lot of side effects, and they're not really treating the root cause of the problem. I love talking about different nutrition therapy for IBD. It's been shown that it's definitely more, it's better for Crohn's disease and ulcerative colitis. It can be as good, if not better, than starting those steroids that can have so many side effects to induce remission in patients. And there are just different types of nutritional therapy here. And basically what you can see is increasing your fruits, vegetables, omega-3 oils from fresh foods, and really decreasing the bad junk foods. Okay, and then surgery. These are the indications for potentially needing surgery in inflammatory bowel disease, primarily with Crohn's disease. Almost 70% of patients will require some form of surgery in 15 years. Many of them that can be much sooner. And then this is something that I always bring up to patients in the beginning, saying this might happen. So they are ready and they know. And usually for Crohn's disease, it's the removal of that bad patch of gut that's not healing with the medications that we have. And then let's see what we have on time. Okay, well, we might be able to finish with all three. One thing that, especially in children, that we always want to be really, really cautious about is how are they doing with this new diagnosis? Symptoms of depression and anxiety are high in patients with inflammatory bowel disease. You can see up to 25 to 30% of patients. 10 to 30% will meet the criteria for a clinical diagnosis. And then things that can make things worse, so stressful life events, family dysfunction, steroid use. Remember, we do not like steroids, but if you use them, that can sometimes lead to some more forms of depression or anxiety, behavioral changes. But what's important is that these rates are similar to children with other chronic illnesses. So that doesn't mean that, this can be probably also seen in diabetes or other chronic illnesses that are diagnosed in childhood. And we just have to be really cautious about making sure that patients have the support that they need once they learn of their diagnosis. These are the questions I got regarding for IBD. So diagnostic methods for IBS versus IBD, telltale signs. So we kind of looked at the two circular graphs for one and the other, and kind of what can be for both, but really a good history, labs, and potentially some stool studies can really start to gear you into the right direction. Do women with IBD have to stop biologic therapy when pregnant? No, they do not have to stop biologic therapy when pregnant. We do like to have you in remission, meaning you're not an active disease and you're not on steroids. And then that last dose of your biologic therapy may need to be adjusted in the third trimester, potentially. And that kind of depends on your GI and your OB-GYN doctors. Are IBS, IBD, and celiac disease genetic? Yes. And any new technology treatments for Crohn's? This is a very specific question. There are definitely new medications that are coming out that are being used more frequently and have been really promising. I did this really cool research on organoids. I finished the research last year, but basically I grew little mini guts in Petri dishes, and you can treat those mini guts and see how they react. They're grown from biopsies of IBD patients. And the theory is that you can maybe have a biopsy, grow your mini gut in the lab, treat the mini gut with different medications and see which medications the mini gut responds to best, and then start the patient on that specific medication, which is so cool because that might be the best medication. So you don't have to go down the line of 2 or 3 before you find the one that could be best for that patient. There is also some stem cell work being done for patients with Crohn's that have fistulas or those connections that are abnormal. So there are definitely new technology treatments coming out, and some might be available more sooner than others. Okay. We have, I'll probably finish up in the next 15 minutes, so it might go over an hour, but we'll finish up with this last topic. So back to Julie. So we know Julie's symptoms, but hey, now this time in this scenario, Julie has some bloating. Okay. So she feels, gassiness, and she also has a weird rash that she wants us to look at. All right. She doesn't have any vomiting, no blood in her stool, no fevers. We do labs, right? And we notice that she has anemia, which we saw with our patient with inflammatory bowel disease, that scenario. But she also has this elevated TTG, anti-tissue transglutaminase antibody. And that is definitely a red flag that this patient is very likely to have celiac disease. So celiac disease, it's a unique autoimmune condition. It occurs in patients that are genetically susceptible, and the changes in their mucosa is due to a sensitivity to gluten. And there is a genetic component to it. However, just because you have this, that means that you definitely can potentially have celiac disease. If these genes are negative, then you do not have celiac disease. However, up to 30% of the general population out there can have one or two of these be positive, and they do not have celiac disease. So it's good to have, but if it's negative, it's helpful because then we can say you don't have celiac disease. But if it's positive, we don't necessarily know if you do. So the environmental trigger, which is gluten, and the autoantigen, that TTG, tissue transglutamase, are known. And the cool thing is elimination of the trigger, complete resolution of the disease. So that is what's really neat with celiac disease. There are associated diseases that are, that if you have one of these, your chances of having celiac disease is much higher. So in this graph, for example, in childhood, so patients with type 1 diabetes are all screened for celiac disease with that blood work study that I showed you earlier. Patients with thyroid disease, Down syndrome, Turner and Williams syndrome, those are very kind of buzzwords in the sense that we know if someone has this, we should look for celiac disease for these patients. And these are some that in adulthood can be more prevalent, where we might have to think about celiac. So this iceberg, the celiac iceberg, is interesting because you can see here the tip of the iceberg are those symptomatic celiac patients. So those are ones that are coming into clinic and saying, hey, I have bloating, I have diarrhea, help me figure out what's going on. But silent celiac disease, there's a ton of patients, 70%, 80%, that have celiac and don't know because they don't have those super strong symptoms that are warranting them to go see the doctor. So classic GI symptoms that can occur in celiac, these we don't see as often anymore because they are screened and seen sooner. But in these two little kiddos, you can have this abdominal distension, like this baby's belly. You can see it pretty big. And in this little one, you can see weight loss or failure to thrive. So really, really thin, problems with their nutrition. They can have chronic or recurrent diarrhea, but guess what? They can also be constipated. So that's the really confusing thing with their bowel movements. They can have belly pain, vomiting, or irritability. And these signs are primarily seen in younger kiddos, like the 6 to 24-month-olds. And then non-GI manifestations can be seen more in the older children and adults. They can also have some of the GI symptoms, but these associated things are seen in older patients. So they can have a rash called dermatitis herpetiformis. I'll show you a picture of that. They can have dental changes. They can have bone weaknesses, bone osteopenia or osteoporosis. They can have short stature, so they're not growing well, delayed puberty, anemia, hepatitis, so inflammation in your liver, problems with joints. I love this picture because it kind of brings together everything that can happen in celiac disease, which you can see that's a lot of different organ systems that can be affected, not just the GI tract. So we can get into a few of these pictures. So this is a typical rash called dermatitis herpetiformis. It is itchy, it's burny. It usually occurs symmetrically. So you can see, for example, in this one patient, both legs are affected. It can be little papules or vesicles, especially on the elbows, in the forearms, on the bottom, on the knees, but really it can occur anywhere. And then these are pictures of the teeth changes that you can see. In patients with celiac disease, these vertical lines that we always want to check if we're thinking about that in our patients. Sometimes patients, we always want to look in the mouth no matter what, but sometimes not just the teeth, but inside of their cheeks, you can see these ulcers that can happen with celiac disease. This is an x-ray of the hips, and it shows these like pseudofractures of the pelvis. So bone issues can absolutely happen. Vitamin deficiencies can absolutely be seen in celiac disease patients. Other things. So 10% of short children and teens can have evidence of celiac disease. So if they're not growing well and their parents are super tall, that's not normal. We need to see what's going on. Sometimes teens can have, females can have delayed menarche, so their periods might be delayed. Anemia, which also can be seen, and you can have fatigue, so you're tired, and you can get lightheaded. And so if any of those things are happening, we want to make sure we're not dealing with celiac disease. So diagnosis, lab work, so that TTG, IgA is what we order in the clinic. We'll also order some other screening labs. So the CBC is going to show us if there's any anemia. And then and if that's positive, then we go to the scope. So we do the upper scope. And celiac disease diagnosis is done by you doing an upper scope. So you do not need to do the lower scope like we did for inflammatory bowel disease. So these are some things that we might be able to see on the EGD. On the left is what a normal small intestine duodenum looks like. Sometimes we can see these things called scallops. So these little bumps here, and then nodules too in the small intestine. But primarily, majority of the patients, we don't see any of these, and we wait for the biopsy results that the pathologist reads to tell us if they see any of those changes. And that's true diagnosis. So what happens in celiac disease, we have in the small intestine, you can't see it in the normal appearing picture, but we have these projections called villi, and they help with nutrient absorption, digestion. And in celiac disease, they're flat. So they're called atrophic. So here on biopsies, you can see usually they look beautiful and these little villi. And then here you can see that you don't have these big, beautiful projections, they're flat. And so when that happens, when the pathologist tells us that, we know this is truly diagnostic of celiac disease. So treatment, a gluten-free diet. Sounds simple, it is difficult. It is really, really difficult. It's really difficult when only one family member has celiac disease. And then you have to figure out how to navigate things around the kitchen, groceries, lifestyle, restaurants, everything to help accommodate that person in the family. I have noticed that a lot of families decide to go gluten-free together to make it easier. So you have to be gluten-free lifelong, and you have to be strict about it. And what does that really mean? What is gluten? So you have to avoid wheat, rye, and barley. So those are the three grains that you have to avoid that gluten is found in. There are also other grains that are that contain gluten, which are not as common, but that all celiac patients need to be aware of. And so where do those come from, right? You know, bread, bagels, cakes, cereals, cookies, pasta, noodles, pies, rolls. Those are most common things that have gluten in them. But guess what? They can also be in other things. So hidden sources of gluten can be seen in things like candy, wafers, gravy, imitation meat or seafood, soy sauce. So it's not that easy just to take out those three grains. You really have to see where else gluten can be hiding. And it can also hide in things that are not food, which is really hard, especially for patients that we see that elevated lab work that we initially get on diagnosis, and it doesn't completely normalize. And they're like, hey, we have taken all of these food things out. Then we really have to dig deep and see what kind of makeup you're using. Is that getting into your mouth? What kind of toothpaste are you using? Is this a little child that has celiac disease that loves to play with Play-Doh and is eating the Play-Doh? That gluten can be in Play-Doh, which is which most people don't think about. Or like when you are sending Christmas cards out and stamps and the glues on the envelopes, they might have gluten too, and you're constantly licking them. So vitamins and over-the-counter medications, these are not obvious, but they can have gluten. So what can you eat? So this, that's really what a lot of my patients ask. It's like, okay, I know I'm going to get rid of this, but what can I eat? And so, or what is safe? And I say, potatoes, rice, corn. These are the safe things you can eat. Oats sometimes can be prepared alongside gluten products. So there's an asterisk for that. And then what are some of the resources for patients to make this easier? So just so everyone's aware, we use our dietitians for all three of these: IBS, IBD, celiac disease. Our dietitians are the best in trying to help navigate this gluten-free diet for our patients. So there are certain websites that are good that patients can go to, local support groups, and then some apps too, because now everything is really on the phone, and it's easy to use your phone picture and scanner. So Find Me Gluten-Free, Allergy Eats. There's an app for restaurants nearby our true gluten-free restaurants. The gluten-free scanner. So if you have something that's like that's not obvious, then you can try to scan that as well to see if it pops up. And so these are the two questions that I got for celiac disease. How do you ensure a nutritious and filling diet plan for those with celiac disease? I primarily use the help of my dietitians. This is a multidisciplinary clinic that the celiac patient comes to, and we work with them heavily. After diagnosis is made, is also referral to dietitian made? Yes, absolutely. So some advice for our future physicians. So take the time to listen to your patient. A thorough history, maybe all that you need to guide you to what the next steps are, or to even a diagnosis that you are doing the next steps to confirm. And so take the time to listen to your patient. So thank you all so much for attending. This is a contrast study here. You can see of the colon that looks like a question mark. If you have any questions, just with time purposes, send them to me on gastrodoc.md on Instagram. I will respond to everybody. So thank y'all so much for having me.
Thank you so much, Dr. Schirtz, for another wonderful presentation. It's always an honor to have you and learn from you.
Thanks.
Everyone, make sure you check out her socials. Her Instagram is gastrodoc.md. And then the Google form is about to be posted in the chat box right now, and it will also be in the description as soon as we log off. So please fill it out within the next 30 minutes for us to receive verification of your attendance. Again, thank you so much, Dr. Schirtz. It's always a pleasure to have you.